Let's move to India with Sivakumar.
Thank you. See you.
Thank you.
Bye-bye.
Bye-bye. Shiva.
Zeke, can you hear me and see us?
We can hear you and see you.
Thank you very much. So thanks once again for the opportunity to transmit our second patient. Here with me, I have my colleagues, Dr. Avanish and Dr. Pramod Sagar. My scrub nurse is Kirtana, and our imaging expert is Dr. Tejasvi, and Dr. Giridhar is taking care of the intubation part. The patient is on general anesthesia. This patient is going to be a SVC type of sinus venosus defect, a superior vena cava type of sinus venosus defect, who also has got, as usual, a partial anomalous pulmonary venous connection of right upper pulmonary vein to right superior vena cava. My colleague Dr. Pramod will give the clinical details of this patient. Pramod.
Good morning, everyone. I hope the slides are visible. Next slide, please.
Yes.
Our patient is a 43-year-old lady. She is a mother of 3 children. She was not diagnosed to have ASD earlier. Recently, she developed NYHA class 2 dyspnea, and during that, an echocardiography was performed which identified a sinus venosus defect with PAPVC of RUPV to SVC-RA junction. She underwent a cath elsewhere which showed mild hyperkinetic PAH, and coronary angiogram was normal. Clinically, she was having features of a pre-tricuspid shunt. Next slide, please. This is a chest X-ray which shows cardiomegaly with a CTR of around 60%. The RA enlargement is more prominent, and there is pulmonary plethora. Next. The ECG was unremarkable. It was in sinus rhythm. The transthoracic echocardiogram was not much informative. It showed RA-RB dilatation. We will be showing a transesophageal echocardiography live once we start the case. Next. Next. This is the CT. We do CT for all the cases. The first image shows that it is a single right superior vena cava, and the right pulmonary vein is draining into the SVC-RA junction. The second image shows that the diameter of the SVC is almost 20 millimeter, just cranial to the right upper pulmonary venous drainage. The caudal edge or the lower margin of the sinus venosus defect is shown in the third image, which is not very low, so it is good. Next. We also found that there was an additional pulmonary vein which was draining about 9 millimeter cranial to the actual right upper pulmonary vein. It was draining posteriorly and almost at a 6 o'clock position, as we can see in first and 2 images. And the third image shows a multiplanar reconstruction which shows that the RUPV can be routed into the left atrium, but this additional pulmonary vein is quite high. In these cases, usually we discuss with surgeon, and the surgeon also felt that this additional pulmonary vein could not be routed during surgery. So this patient is planned for a transcatheter closure. Next slide, please. This is the schematic representation of this patient's anatomy. In the first slide, in the first image, you can see that the RUPV is draining into the SVC-RA junction. There is an additional pulmonary vein draining above. So in order to prevent occlusion of this additional pulmonary vein with the cover stent, the common strategy that is followed is we use a bare metal stent on the top and a cover stent on the bottom in an overlapping fashion. And in this case, we are planning to do a new thing which will be shown during the procedure.
Yeah. Great case. Excellent. Yeah. So, Sivakumar, I'm going to open this case for discussion.
Yeah.
On the panel here, Alpai, in your center, would you do this transcatheter or surgical because of this additional anomalous vein?
At this age,
go closer.
I think at this age, maybe we can do transcatheter approach because it's an older age, but I am not sure in the adolescents, in small kids, such as below 16, 17 years old.
So you're worried about the age of the patient?
Yeah, the age is good because in smaller age, I am a little bit concerned about.
Okay, thank you. Huwaida?
I mean, we would consider it in an older patient, but we have not been doing it in younger patients.
Okay.
Or I think. I think the upper pulmonary vein is pretty small, so by MRI you can estimate how much flow is coming from it. Just don't occlude it.
Okay. Dr. Jojo?
Exactly, that's what we would do. We would discuss, of course, all these patients with our surgeons. So we think this is a team decision how to treat them, but we consider older patient for this treatment, and we would treat this patient, I think, interventionally as well.
Thank
Yeah,
you.
also we do the same and we discuss the patients with the surgeons and if it is age and the weight is okay, then we go with either transcatheter or with the surgery.
As a surgeon, we discuss with the cardiologist and decide what to do. I think, in my opinion, it is better to surgical intervention.
Surgical intervention.
Yes.
Thank you. Is Zuhair here?
Yeah.
Yeah, Zuhair, we have a surgeon here. Zuhair, do you want to come to the microphone and tell us your thoughts as a surgeon when you see this patient? How old is he exactly, Sivakumar?
43 years.
43.
She's a
So he's an adult.
43-year-old lady with mild pulmonary arterial hypertension, normal coronary angiography, and large left-right shunt.
Great. Zuhair.
This particular patient, I think, probably better served surgically. This is an emerging new technology. We still don't have long-term follow-up as much as we have for surgery. And it all depends, of course, on the experience of the center, but there is no doubt that percutaneous intervention is feasible. But I always say to our cardiologists that the fact that you can do it doesn't mean that you should do it.
Now, Zuhair, what would you do for the higher up vein? Would you re-implant it or leave it?
There are multiple surgical techniques to deal with it. One of them is you can just divide the superior vena cava above that particular vein, close it, and re-implant the superior vena cava higher up into the RA, again using the atrial appendage. It can also be routed inside, and the SVC can also be enlarged by patched and enlarged. So there are multiple surgical techniques to deal with it.
Great, thank you.
Ziad, I have two
Ahmed,
questions
ask.
for the surgeons. Yeah, Zohaib and Ahmed. Yeah, is it technically easier? I mean, it's a small vein and long vein, and to do a connection just inside the superior vena cava. What about the long-term patency of it? Because of you will use a graft for this, I think, or saphenous vein.
Okay,
like
let's
this.
see what
And also,
Ahmed
is
says.
it fair to do it? Yeah.
Zuhair?
Is it fair to do it because it is very small? And
Generally,
also, good idea to put a.
Numbers were 17.
We are,
out
if
of
we see
100.
at the surgery, we will connect that vein to the left atrium. We will do the tunnel in the superior vena cava. Also, we are enlarging the superior vena cava with another patch. If I saw a pulmonary vein that is going to the right side, I usually, most of the time, do the same thing.
Okay. Zuhair?
and the patching material for ASD is usually the flesh autologous pericardium, which really generally does not calcify and will not generally cause future problems in terms of stenosis or obstruction. So the chances of obstructing the vein are minimal.
Okay, thank you.
Make it quick.
Sivakumar, back to you.
See, I heard all the opinion. Of course, I mean, we respect a lot the opinion of senior surgeons like Dr. Zohrail Halis. And I would thank the senior surgeons for coming for these meetings, and it's extremely good to have a surgical participation. We had a surgical discussion. This right upper pulmonary vein has got a distance of 3.5 centimeters superior to the cavo-atrial junction, and so the surgeon felt that in a 43-year-old lady, he would prefer to leave it to drain into the right superior vena cava. The vein was measuring about 9 millimeter in diameter. Anyhow, now the strategy that we follow, we have completed 135 patients of sinus venosus defects so far, and our incidence of an additional right upper pulmonary vein draining above the main right upper pulmonary vein is close to 15% among the cohort of 135 patients whom we have completed so far. Previously, we used to do a strategy where we will mount a uncovered stent on the top and a covered stent on the bottom simultaneously on a long balloon, position the uncovered portion to straddle the additional upper pulmonary vein and the covered portion to straddle the lower pulmonary vein. But today we will have a different strategy. I'll show the angios later. My imaging expert, Dr. Tejasvi, will quickly run through the transesophageal echo because we didn't show the TE. Yeah, please, Tejasvi.
Good
Good morning, everyone. This is a metaesophageal 0-degree view, which shows significant RA and RV enlargement.
We don't see, this is the echo, right?
Sorry?
Yeah,
Showing-
transesophageal live. Yeah.
Okay.
Next.
Yeah. This image is showing the sinus venosus defect on the top of the screen, again in a 0-degree view. This is a long axis view of the same at around 90 degrees, and here you can see the SVC entering the RA and the sinus venosus defect communicating there. This is a color Doppler interrogation of the same, which shows the left to right flows through the sinus venosus defect.
So, after seeing this anatomy, our next step was to have a transeptal puncture. So, this is a transeptal puncture that we were doing run live. This is a transeptal puncture with a broken bro needle that we do. Can you show me the transeptal puncture? That is actually the transesophageal echo now shows the transeptal puncture being done on the oval fossa with a broken bro needle. Next picture. So after getting the transeptal 8 French sheath, the next step was to show the next. The next step was to confirm that we were in the left atrium, and then next advance a right coronary catheter up to the tip of the transeptal sheath. Next. So we turned the transeptal. Show the previous image. Show the previous. So after getting the Mullin sheath, the right coronary catheter, the guide wire, the entire assembly towards the left upper pulmonary vein, we pulled the Mullin sheath. We gave a clockwise torque in order to twist it towards the right upper pulmonary vein. So this is the sheath turning towards the right upper pulmonary vein. After this, we advanced the pictorial catheter into the right upper pulmonary vein. Then from the right femoral venous catheter, we advanced the a catheter into the azygos to locate the position of the azygos. Next picture. Then we knew that there was an additional pulmonary vein, so we cannulated that additional pulmonary vein. So the right femoral venous catheter is in the right additional pulmonary vein, and the lower catheter is in the main pulmonary vein. Main pulmonary vein is obviously 4 times as large as the additional pulmonary vein. Next picture. So after this, we did a balloon testing using a 24 millimeter long 8 centimeter balloon. You can see the simultaneous adjacent picture, transesophageal echocardiography, completely showing an occlusion of the sinus venosus defect and redirection of the right upper pulmonary vein towards the left atrium with laminar spectral Doppler flows from the right upper pulmonary vein towards the left atrium. So this confirmed that we have completely occluded with this 24 millimeter balloon. At this point, we decided to do an angiogram. Show the angiopic. So this is the right additional pulmonary vein that is being injected. We wanted to see whether the right upper additional pulmonary vein will also get committed towards the left atrium, even though that is not expected because it was draining clearly more than 1 centimeter above. But we just wanted to see the location. So this balloon is occluding that right additional pulmonary vein. Next picture. At this point, we checked for our main pulmonary vein. Next picture. Yeah. So this is the main pulmonary vein being injected, which shows that by and large, a large amount of the right upper pulmonary vein is redirected towards the left atrium. There is a tiny whiff of residual flow. That residual flow is because I have a parallel catheter that is running up to cannulate that additional right upper pulmonary vein. You can see that there is a 5 French guide catheter that is running parallel to this balloon, and that was the reason why there was a tiny residual flow. Next picture. So at this position, what we thought was we will get a guide catheter into the additional pulmonary vein and the regular catheter. Next picture. And make a simultaneous angiogram. So the first part of this picture shows the main right upper pulmonary vein completely getting routed towards the left atrium. Later I gave a second injection to show that that right upper pulmonary vein, additional vein, is getting occluded by this balloon. So this is a simultaneous 2 angiograms being done. The initial angiogram is done on the right upper main pulmonary vein, and the second angiogram is done in that additional right upper pulmonary vein. Next picture. So this is the final last angiogram that we are showing. So you can appreciate this is in an AP projection. I'll run this angiogram slowly. So we can see that the 24 millimeter long cylindrical balloon is occluding the right upper pulmonary vein fully, redirecting the right upper pulmonary. Go back, go, freeze it, freeze. Is redirecting the right upper pulmonary vein is completely getting redirected into the left atrium. Go further, go further. So we can see the full left atrium getting filled, left pulmonary veins getting filled. There is no residual flow into the right atrium at this point. Now LV and aorta keep filling, keep running, keep running. Towards the end of this injection, I inject into that additional pulmonary vein, freeze, freeze. So this additional right pulmonary vein is getting occluded by this balloon, and as I deflate the balloon, keep going. As I deflate the balloon, we can see that that pulmonary vein now drains into the superior vena cava. Keep running. As we continue to observe, as I deflate the balloon, the pulmonary vein empties out. So what we are planning to do in this patient is a new type of stent that I want to show you here. So this stent, can you bring the image here? Make the photo bigger. So this is a stent which has got two components. So the last 15 millimeter, the stent is made by Zephyr. Turn around, turn. So this stent is Zephyr. This is an Indian made stent. It's a cobalt chromium stent. Come back here. So this stent has got an 8 centimeter length. 65 millimeter is covered, 15 millimeter is uncovered. We have got a guide catheter coursing through the lowermost strut. I have taken it through the lowermost strut of the uncovered part, and this is the covered part. So now we are going to be loading. This is that same 24 millimeter balloon. So I am taking this 24 millimeter balloon inside this covered stent. I am peeling off the sleeve. So the sleeve of the balloon is peeled off. I get the balloon centered. So this is a 8 centimeter long Z-Med balloon, the same balloon that we did the balloon testing. So now this is, I'm going to use a crimper. So this is the crimper. In this crimper, this is something similar to an Edwards crimper. It's something similar to an Edwards crimper.
So Sivakumar, you said the Z-Med diameter is 18?
Z-Med diameter is 24 Z, 24.
24, but length is 8 centimeter.
8 centimeter, yeah. See, I'm using the crimper. This is a crimper made by the Zephyr. I'm standing on the opposite side in order to show you the video.
And in the groin, you have a dry seal sheath?
I have a 24 French cook sheath.
Cook sheath.
Cook sheath. I will show you before I tighten the crimping further. Can you get it focused? So here, I'm using a double wire, one catheter plus one balloon, single stent strategy. So I'm going to be, are you able to see it, Z? Z, can you see the picture?
Yes, yes, very clear,
Okay.
very nice.
So I'm going to use further crimping in order to get it into much lower profile.
Shiva,
Yeah,
you have
yeah.
you have the catheter passing from the strut, yes, correct?
Yes, from the junction between the, is it my,
Yes,
yeah,
yes, Shiva.
so I will show you my, once again, I will take it out and I will show you in a much more magnified way. Just give me a second.
Very interesting, actually.
I will come closer to the camera so that you can see it far better. Yeah. Now I will show you.
Okay.
This is the covered portion, the uncovered portion, the junction I have come out. Can you see that?
Okay. Yes, sure.
So right now what I'm going to do is, I need a protective sleeve. So I have taken an 18 French sleeve, I have slit it longitudinally, now I'm going to cover it. Can you see that? I am slitting it. Because this is now going to be much larger in its profile than what I anticipate. So
That's why I think, it's better to use the dry seal sheet because you don't have a valve. It will go in without any problem. But that's
morning I told you, see, India has not
Don't have them.
registered a Gore products.
I understand.
So now I will show you how we have crimped. Can you see the cut sleeve here?
Yes, yes.
Yeah. So this is sleeve that I am modifying a little bit. So at this point, I am taking out the stillet. I am taking out this guide wire out of this. So now I have two guide wires that are coming out here. One is the Lenderquist and one is the Amplat Superstiff. I'll show you now a fluoroscopy. Pramod, get both together. I'll show you a fluoroscopy. Come down. The right upper pulmonary additional vein is having the Amplat Superstiff, and the main superior vena cava is having the Lenderquist. The Lenderquist is parked in the jugular bulb. I don't take jugular venous catheter for railroading and circuiting. So come down. So it's parked in the jugular bulb sigmoid sinus, that junction. After carefully looking at the position, and then we park it and we don't move the wire. So now Dr. Pramod is getting both the catheter, the balloon catheter, and the guide catheter in the respective guide wires. When it comes closer, I am going to show you.
That's fine. While you're doing this, I'm going to ask the audience by show of hands. In your center, do you do transcatheter repair of sinus venosus ASDs or surgery?
Wait, goes.
Transcatheter, raise your hand, please. Okay, surgery. Obviously, there's still the majority in the world, they use surgical repair of sinus venosus ASDs. Hopefully this case and the case that Ahmed will do, Ahmed and I will do on Friday or Saturday, Ahmed?
Okay, keep both wires.
Friday, will teach some of you the transcatheter technique, tips and tricks to start a program.
Recently Dr. Eric Rosenthal made a total world registry, and now he has included close to 380 patients, and the world experience is slowly increasing further and further.
Yes.
We contributed. Yeah, we contributed about 135 patients in that cohort of the total world experience of 380 odd patients. And
obviously you have the largest experience in London, in our center in Doha. We do a lot of
so now you see that I am taking this combo protected by the sleeve through this valve, make this larger, we don't need fluid. So now I'm going to go inside. So at this position, I'm going to advance this assembly. Show this only. Show the camera only.
Yeah, we see it. We see it.
So I'm advancing the total assembly.
Yep.
I want one. I'm just removing this sleeve. One artery forceps here. So I'm peeling away this sleeve. Come back here. Now go do fluoro. Or holding both.
Okay, let's see fluoro now.
Yeah, this is now live fluoro.
And the tip of the sheath is in the RA.
Is in the inferior vena cava RA junction. Yeah, let's just in the lower part. So now I'm advancing my both assembly together. Fluorostore. At this point, the Judkins right coronary guide catheter is on the amplathe superstiff wire, and the second catheter, Shobo.
That's good.
So I'm actually, can you go to RAO 30? I am pushing it up so that I get into the carina of the combination. Move the, no, make that picture larger. Take the transesophageal out to Tejasvi. Little out. I'll take a cine. We can see the separation now. I'm pushing it even further up. Okay. So now it's precisely like a double balloon, a single stent, double wire strategy. So my uncovered portion, run this. My uncovered portion is on the superior vena cava above the this pulmonary vein. So what we'll do now is come back to the AP.
Sivakumar, I mean, this view, I think you're going to need to come way more proximal because you will not be able to close the ASD with this.
We tested Z. Now go to transesophageal and show the caudal end of the stent.
Okay.
Transesophageal, show the caudal end of the stent. Yeah, around 120. Push it inside. Yeah. Now turn it around and show the caudal end of the stent. Yeah, correct. Turn it around. Yeah. See the stent is much extending far beyond. Show
Okay.
to us little leftward.
Yeah, keep that view and with the color Doppler when you inflate.
Yeah, we will do that. So transesophageal echo small screen and this one big screen. No,
Good.
you will have both. Okay. Now little RAO so that we see the difference. RAO, RAO. That's fine. That's fine. Okay. Now you are ready. Now Pramod is going to inflate. Keep inflating the. Yeah. 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 Go to around 3 atmospheres. Tejasvi, now make the transesophageal bigger. Enough. Transesophageal bigger. Transesophageal bigger and. Now show the color flow. Okay. This is the superior vena cava, the balloon. So Tejasvi, push it inside and show. Yeah, that is the right upper pulmonary vein. Push it inside. Okay. Yeah. Now leftward and show the balloon. Correct. So they go push it further and show that there is no residue. Yeah. Okay. Now you complete the inflation. How much is it?
One.
Fluorobic. Yeah. Yeah, deflate. Fully deflate.
Yeah, the SVC proximal near the high vein was not very big, so be careful to, because there
Yeah.
was a waste with the balloon when you inflated the balloon, remember?
Yeah. So now we have completely deflated. Transesophageal echo bigger. So rightward rotate, that is the right upper pulmonary vein completely getting rerouted towards the left atrium. Doppler color flow. So this is a low velocity Doppler flow of the right upper pulmonary vein. Color flow again. Now with this color flow, slowly rotate leftward towards the superior. That is the SVC stent now. We have covered the caudal edge of the sinus venosus defect, and at this moment I'm going to do an angiography of the right upper pulmonary vein. Get ready for an angiography. 15 at 15. Connected.
You can elevate the TE probe up.
TE probe
Pull
up.
the TE probe.
Yeah. Yeah. Ready for
Good.
injection.
Yeah.
So this is the upper pulmonary vein draining. This is possibly some amount of restrictive LV physiology. I am going to give you pressure transducers also. Filling only the left atrium. We already saw that the pulmonary venous flows on Doppler was laminar with flow reversal. Show the spectral Doppler once again. I'm giving you simultaneous right upper pulmonary vein and left atrial pressure. Can you give me an artery forceps? Just open this one. So this is the right upper pulmonary veins laminar flows. I have tightened the angiographic syringe too much to the pigtail, so I am undoing it. So now I am getting two pressures, one of the right upper pulmonary vein and one of the left atrium. Flush. Show the pressures in scales of 20 and show the pressure big. So this is the right upper pulmonary vein. This is the right upper pulmonary vein to left atrium. Can you see the hemodynamics I am showing bigger? Is the picture seen, Z? Hello?
Yeah, I see.
Okay,
The pressures are good. There is no gradient.
Yeah.
Slightly elevated, of course, and that's from probably
Some amount of restrictive LV physiology. That in fact we were able to see little flow reversals in the spectral Doppler flow on the pulmonary vein. See that now in this. Can you put a Doppler again? We can appreciate that the flow reversals are also a little prominent. What is coming towards the transducer is the flow reversals, and the flow reversals are prominent, indicating some amount of restrictive LV physiology. So currently what we are going to do is check on the right upper pulmonary vein, additional vein, whether that is flowing well into the superior vena cava. So I'm going to do. So the reason for taking a guide catheter over this amplathe
you can just inject in it, remove the wire and inject in that vein.
I'll do that also. Now at present I am trying to use a I'll do the first injection with the wire and second injection without the wire.
A question on this Zypher stent, is it approved, CE approved, is it available?
It is available, it is approved in India, Indian government has approved it. It is in the process of CE approval applications. So it is expected to get a CE approval in the next 6 months. So right, this is the right upper pulmonary vein. As you suggested, my next step will be, without the guide wire, I will make a second injection to show the pictures far better. So
You can just dilate the strut into that vein.
Yeah, that 24 balloon.
Small balloon, 8 millimeter balloon, just dilate that strut and should be okay.
So right now what we are doing is, I am getting,
Yeah.
so this right upper pulmonary vein is now allowed to drain into the superior vena cava stent. And I'm going to make one last angiogram of this picture. One last angiogram of this main right upper pulmonary vein. Ready? So this, ready? Come towards me. Yeah. Freeze the image and show. Freeze it. Go back, go back, go back, 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 back. Okay. There is a tiny amount of a residual flow that is seen. I wonder whether it is through the septal puncture site that we have done, but we are clearly delineating the caudal edge of the left atrium very, very clearly. Show a live transesophageal echo now. Yeah, make the TE bigger.
With the TE.
Yeah, now you see that there is a small flow around the septal puncture. Can you see?
Yes, yes.
Just freeze it and show. Freeze it. Yeah, go back. Couple of frames back. See, see there is a tiny flow that is around the septal puncture, and that is giving this picture. Otherwise, show the sinus venosus stent once again. Yeah.
Can you explain why the pulmonary veins are so dilated? I mean, they look a bit dilated.
Restrictive LV physiology, we are showing that the pulmonary venous pressure now is about 16 millimeters of mercury. When I started, it was somewhere around 8 to 9 millimeters. It has increased to 16 millimeter. I will give a pullback from the pulmonary vein into the left atrium and right atrium, and you will appreciate that a 43-year-old lady having some amount of restrictive LV physiology. All these years, the left ventricle was not getting fully filled because of the pre-tricuspid shunt, and suddenly now a reasonably elderly person is getting in the full cardiac output going into the...
Sivakumar, make sure to put this patient on some diuretics and afterload.
We will do that. But 16 is not very alarming, because this patient is on positive pressure ventilation now. So once I take out from the ventilator, probably there will be another 2 or 3 millimeters further reduction also. Can you show the stent part nicely? Pull the, now color. That is the wall of the stent. Completely the sinus venosus defect is closed. I'm going to now do a pressure pullback from the pulmonary vein into the left atrium and then into the right atrium. In the meantime, we will take out this balloon. Can you take out this balloon?
Hey, Siva, this is Hueda. This is an impressive case. Why is her right diaphragm paralyzed? Did she have something done? And is that why the stent looks like it's pretty far down? Just her right diaphragm is quite elevated.
Yeah, it's not moving much. However, that's nice observation. Probably there is something like an eventration. She has never undergone any surgeries so far, and she's on a positive pressure, full ventilation. So it is not like even if there is a diaphragm palsy, the diaphragm should move. Probably something like an eventrated diaphragm. I will look into it, However, we didn't see that. Yeah, no problem. Take it out. Great observation, Hoveida. In fact, Hoveida was kind enough to make me write the chapter on sinus venosus defect in the intervention clinics, a small handbook that she and Frank Ing are publishing. Hoveida, is it going to be in another few months?
Yes, it's coming out very soon, and
Yeah.
your chapter was amazing, and you're doing some excellent work there.
Yeah, thanks for being kind enough to include me among like all the authors, and it was a very it's a significant pleasure for us. So now I'm going to show live the pressure from the pulmonary vein into the left atrium and into the right atrium. Show the pressure live. So this is the
We have a question from Gregor. Go ahead.
I belong to the center which would do this surgically, honestly, and I'm looking forward to learn more on Friday. Having said this, in this more than 300 cases which you mentioned earlier, is there any sinus nodal problem? Is there any thrombus problem? And what we now discussed, diaphragma, are there patients with phrenic paralysis? Could you comment?
Gregor, a great question. Actually, we have done about 135 till now, and we did not have a single incidence of sinus nodal problem. But in the world literature, when Eric Rosenthal collected all the data, there was one patient who developed significant sinus bradycardia and subsequently needed an atrial pacemaker. Having said that, the course of the sinus nodal artery in the superior cavo-atrial junction is epicardial. So by giving a pressure from inside, an epicardial artery will not be injured a lot. On the contrary, when the surgeons do the dissections, the epicardial artery is more likely to be traumatized, not necessarily directly, but even by the incisions in and around it, which will produce fibrosis and will lead to sinus nodal arterial strictures over a period of time. So the chances of sinus nodal injury, I think with either a balloon expandable or a covered stent is by and large very uncommon. The reason being the artery is epicardial. Now this is I have pulled back the sheath into the right atrium. So the catheter, one catheter is in the right upper pulmonary vein and one is in the right atrium, and this shows how much of restrictive LV physiology is there. While pre-procedure, both the right and the left atrium were 9 millimeters of mercury. Now the left has increased to 16 to 17, and the right is now at around 8. I'm going to make a pullback of this entire pigtail all the way down into the right atrium. So now I am in the right atrium, and the right atrial pressure is around 9 millimeters. Of course, as Z told, we will give a diuretic dose, maybe for a week till we observe stable hemodynamics. Last echocardiography, transesophageal. Now that the catheters are out, Dr. Tejasvi is going to show the right upper pulmonary vein first. Show the Doppler now. Pulse Doppler. So this is the pulse Doppler with the flow reversals going below the baseline. Now show the color Doppler across the sinus venosus defect. Yeah, just leftward rotate, correct. So now that is the whole stent. The stent is not having any residual flow at all. Now go to the fossa vallis region where we gave a septal puncture. So that is the septal puncture site. Rotate it till you get the septal puncture nicely open. Or come to 45 degree. Yeah, that is the septal puncture. So the septal puncture site is now acting like a left atrial pop-off. Hopefully it should get sealed off in a matter of time. Go to about 45 degree and demonstrate the PFO, the septal puncture far better. Yeah.
Great. This is very good demonstration, Sivakumar. So we're going to open the floor for questions from the audience. Please, if any of you has questions, come to the microphones in the back, because we have about 8 minutes waiting for Mario to be ready before we go live to him. Questions from the floor. Turn the lights on, please. Lights in the room. Question there. Leif.
Thank you so much. This is a masterful presentation. I have two questions. One, at what point in time you would consider enlarging the sinus venosus? Do you do that based out of CT or just hemodynamic measurement? And number two, if the surgeon tells you that they plan on doing something more extensive like a Warden, Does that push you to consider this procedure more? Because we know the warden long-term may not have similar outcomes like a two-patch or a single-patch technique.
Okay,
Great questions.
I will take the second part of the question. Warden's anastomosis in a younger child is far more easier. The reason being, you are disconnecting the superior vena cava just below the junction of the two innominate veins and giving a traction to it towards the right atrial appendage, and you are getting an anastomosis. In a small child, the tissues are far more stretchable, and so they behave far better. But in a grown-up patient, in an adult, whenever we do a Warden's procedure, the stretch of the superior vena cava and the stretch of the right atrial appendage will lead to strictures of the superior vena cava as well as the right atrial appendage anastomotic area. And we have seen patients who presented with significant superior vena caval syndromes. So my surgeon will be very happy to do a Warden procedure in a younger patient who is having an additional pulmonary vein draining high above, but not in a patient who is 43-year-old. The distance between the superior vena cava, the junction of the superior innominate veins to form the superior vena cava, to the place where the right atrial appendage was is close to about 8.5 centimeters. This 8.5 centimeters, you have to give a traction. The right atrial appendage tip has to be pulled up, and the right superior vena caval high portion has to be pulled down. So this stretch is not a great idea. It definitely avoids possibility of sinus nodal dysfunction. However, it causes quite a lot of stretch, and so may not be a great option in a grown-up patient. The second question about superior vena cava, how much you will enlarge. Our usual routine is we do a CT scan. In this particular patient, the superior vena cava just above the right upper pulmonary vein was 20 millimeter. Our standard practice is to go 4 millimeter higher, so it was 24 millimeter. If the 24 millimeter balloon is producing a complete occlusion of the sinus venosus defect, we stop that. If there is a small amount of residual flow, we upsize by 2 millimeters, that means 26 millimeter. If there is a right upper pulmonary vein obstruction with the pressure gradient, we downsize it to 22 millimeter. So our strategy is superior vena cava plus 4. If there is a pulmonary vein obstruction, minus 2. If there is a residual flow, plus 2.
Thank you.
Having done a few, now we have always observed that whenever we use plus 4, invariably the first balloon will produce a complete occlusion. We don't use a compliant Amplatzer sizing balloon. We always use a semi-compliant ZMED balloon or a BIP balloon. Again, it is ZMED. I'm not telling that just because PICS is organized by Ziad, it is one of the excellent balloons, and I find that using a semi-compliant balloon tells me that I'm going to just exactly reproduce the same result with my covered stent, because the diameter of the ZMED balloon and the diameter of my covered stent are going to be exactly the same. The same thing I cannot expect on a compliant sizing balloon. So we use always a non-compliant, a semi-compliant balloon. I'm going to take a figure of 8 while I'm ready to take questions further.
While you're doing the figure of 8, we have a question on the floor.
Thanks so much. Excellent presentation. This is Arash Salabitabar from Nationwide Children's. Have you had any experience with late pulmonary vein stenosis of the additionally anomalous pulmonary vein that you cover with bare metal stents? Have you had problems coming back to the lab to redilate side struts or intervene on those at all?
I heard the question partially. Is it about pulmonary vein getting occluded?
The question is on the higher pulmonary vein. Have you had cases where there is some stenosis and decrease of flow that you had to go back and dilate the strut into it?
No, not at all. So far, no. Actually, in all the cases, what we do is we mount a uncovered stent on the top and then a covered stent on the bottom. We overlap the two. Recently we started getting this hybrid stent where the upper part is open and the lower part is like covered, and we have started using this for these additional pulmonary veins. We never go and redilate any of the struts. The reason being, these are veins that are very small, measuring 8 millimeter or 9 millimeter. I go and put in a balloon and create some minor endothelial injury. They will be the harbingers of further pulmonary vein stenosis. So we try to avoid unnecessarily causing an endothelial injury on the pulmonary vein.
Great.
Siva, regarding the ASD, is there a particular sinus venosus ASD that you say it's either too big or too relatively low that you will say, I can't do it? Does the ASD affect your decision on whether it's doable or not?
I mean,
That's my lecture.
you are talking on an additional associated secondum ASD or the same sinus venosus defect size itself being large, Hoida?
The sinus venosus, if
Okay,
the sinus venosus is really big.
we have written in our original paper in circulation intervention that if there is a substantial caudal extension of a sinus venosus defect, that patients are less likely to be completely getting occluded. But what is definition of a caudal extension is, if I have the transverse diameter of the superior cavoatrial junction, and then the vertical dimension of the sinus venosus defect, put in a catheter, no? If I have the transverse diameter of the superior cavoatrial junction compared to the vertical extent of the sinus venosus defect from the cavoatrial junction on a transesophageal echo, if the vertical extent is like 1.5 to 2 times the transverse diameter, then these patients are going to be difficult to close. When there is an additional secondum atrial septal defect, quite often it is easier. We will be able to put in a come down on the IA. I'll take out the guide wire. So, so we have had about, among these 135 patients, 8 patients had an additional significant secondum atrial septal defect, which were as large as 10 millimeter to 36 millimeter, and we have used standard Amplatzer septal occluders in these patients. In fact, in one of the patients there was a double atrial septal defect. We had to put in two devices. So now I have taken the Lundquist device out, and now I'm taking the coronary catheter out.
Great.
So now I'm going to tighten the figure of 8. Come here.
Sivakumar, we have 2 quick questions from the audience, and then we'll leave you alone.
Sure.
Go ahead.
Take it out.
Thank you.
The procedure is over. We see. I'm just yeah.
Okay. My question is: are you ever scared that this gets embolized at any stage? Because in Doha, I know that they do it in a different way, where a thread is put in the distal stent, the distal strap. So, any risk on your experience for this being embolized?
Yeah.
And the second question is: do you think the stent was a bit too long, going all the way?
Thank you. Go ahead, Sivakumar.
So in covered stent, the stent embolization, we have had in our 135 patients in 5 patients. 3 of the patients happened after we removed the guide wire circuit. So in these 3 patients, they straight away went for surgery. Whereas in 2 of the patients, they happened while still the vein circuit was still present. That means I had a stiff wire running into the right jugular vein. In these patients, I put in an additional overlapping stent, and I was able to rescue the patient without sending them to the operating room. So, so the answer for the question is, if you have a guide wire circuit still present, you will be able to push the lower end of the embolized stent in the right atrium up with a compliant balloon, something like either a Cook Coda balloon or something like a Medtronic Reliant balloon. And then once I push the
Sivakumar, we need a quick, because Mario is ready, so quick point, and then
there are ways of tackling an embolized stent if it is within the wire by using an overlapping stent, covered stent.
Great. Thank you, Sivakumar. We're going to leave you in peace. Excellent case presentation. Very nice technique. Thank you so much.
I would like to thank the entire PICS for giving us this opportunity. I would also like to thank all my colleagues here who are doing a phenomenal job in getting both these cases. Thank you very much.